is to talk about safety crisis plans. I'm looking at the number of attendees here. It seems like there's a lot of interest in learning more about them. This is the second of an ongoing series of trainings following the initial training on the directive 4.300, which is kind of the gap or the bridge to the behavior support rule that's currently being looked at and hopefully will be in place soon. So the purpose of today is to talk about what a safety crisis plan is, kind of zoom in on all the things that go into making one, and then to kind of walk through one template that was provided in the directive. Thank you, Heike. Heike will be my slide mover, so there might be a little bit of a lag as we kind of move through material as she's doing 4 jobs right now. So bear with me a little bit, and we will get through this hopefully successfully. So today what we're going to look at is we're going to do a real quick review of the directive. We're going to define what a reactive strategy is, and specifically talking about those reactive strategies that we're most concerned about. We're going to talk about what a safety crisis plan is. I'm going to answer some common questions about safety crisis plans, which is probably what 125 of you are here to learn about. We're going to talk about what common factors you should be considering when you're writing a safety crisis plan, and then we're going to end off talking about what the components are, kind of an option of how you might lay them out, and what the purpose of each part is. So just to review Directive 4.300 real quick, the purpose of the directive is to make sure that we're in compliance with the HCBS, the Home and Community-Based Standards, that ensures our continuation of CMS funding. So this is funding from the federal government. The directive also ensures that when we have limitations to rights or restrictive interventions that limits people's rights, that they're justified, necessary, and appropriately implemented. So it also ensures that the clinical and the clinical and the planning team are overseeing what's occurring on a regular and consistent basis, so we're actually looking at what we're doing. And it also defines what the requirements are for the use of physical interventions, chemical interventions, and which practices are prohibited. Final purpose of the directive is to delineate the responsibilities, so to separate the responsibilities out and achieving the HCBS compliance by each level. So regional office providers, support coordinators, regional behavior support review committee, and for the purpose of today, we're going to talk about safety crisis plans. So we're going to delve into what a safety crisis plan is. We're going to talk about when they're indicated and when they're required. So here's a quick kind of visual of what the process for the directive lays out. You might notice this is a little bit different than what you had previously seen. There has been a recent update to the directive that was released, I think, last Friday, so I would highly suggest that you guys go out and read that if you haven't seen it. But this is the most updated version of the directive, which is close to what the draft rule is going to look like when it's finished, hopefully. And so let's just kind of walk through this real quick so you have an idea of what the requirements are. So that first piece of one reactive strategy that is restrictive, so that's a key change in the directive, and we're going to talk about what that means in a second. So if you have one instance where you use a reactive strategy that's restrictive, or you have a history of needing to use that level of response, then you need a safety crisis plan. Again, we're going to talk about all this stuff in detail, so don't get bogged down too much on what everything is. Let's just walk through it. So once you have a safety crisis plan, you're moving along. Once you reach the reactive strategy threshold, which is defined in the directive, and this is different too. This is not the same as it was before. So now we're looking at 5 or more reactive strategies that are also restrictive in a 1-month period. So 5 times you've used a reactive strategy that's also restrictive in a 1-month period. At that point, you have to use that formalized planning team review that's laid out in the directive as a requirement. This is when you would do that. Now, this isn't the only time you can do that, but this is when you must do it. And moving along, if you've reached threshold for 3 consecutive quarters, so this is using lots and lots of reactive strategies are also restrictive. So 3 consecutive quarters. You should consider referring that person, or the planning team should consider referring to the Regional Behavior Support Review Committee. You don't have to refer to the Regional Behavior Support Review Committee, but man, it would be a really, 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 really good idea if you take advantage of that free consultation. And then once you've reached threshold for 3 or more quarters in a 2-year period, so these aren't necessarily consecutive quarters, but just any time you're reaching threshold across a 2-year period, 3 or more times, you need to request behavior services. So this is not an option. This is you must request behavior services. Now, you don't have to wait until this point. In fact, it would be a really good idea to not wait until you've met threshold this long for 9 months out of a 24-month period. So you should and you can request behavioral services much earlier on, but at the point where you've had kind of bad outcomes or you've had a lot of restrictive interventions in that period of time, you have to request services. That doesn't mean that there will be services available, but you need to be requesting them. So let's talk a little bit about reactive strategies, restrictive interventions, and rights restrictions. So these are all kind of related. This is a nice little graphic that Dr. Rogers came up with, and it's a Venn diagram kind of showing you how everything kind of overlaps a little bit. It's really important to recognize that sometimes you have strategies that fall in one but not the other, and sometimes you have strategies that fall into all three. So it's really important to recognize what the context is. It's also important to recognize that restrictive intervention is a CMS term and definition. So that's not something that we created. This is something that the federal government has defined for us. So we're complying with what it says. So here are some questions to start asking yourself about how to determine what sort of strategy this is. So if you're doing it in response to somebody's behavior that's an undesirable behavior or something you don't like, it's a reactive strategy. If the aim of the strategy is to change the behavior, or to change the environment, or change the situation that the behavior is occurring in, it's a reactive strategy. If you're doing it to reduce the risk associated with behavior, it's a reactive strategy. So this could include things like validating somebody's feelings, as you reacting to a situation to try to improve the situation. Could be a stay close hot. If you're a tools agency, you stay close hot as a de-escalation strategy. That's a reactive strategy. It might be moving breakables away from an area in which a person is really upset. Again, we're not talking about whether this is a good idea or a bad idea. We're just identifying situations that are reactive. Remember, that's reacting to a situation. Asking somebody to leave the room, asking other people to leave the room. That's a reactive strategy. Turning off noise, making the lights a little dimmer, using physical crisis management strategies, or even seclusion timeout. These are all reactive strategies that may or may not be used. So restrictive interventions, which again could be reactive but may not be reactive, questions you need to be asking yourself to determine is this something that restricts somebody's movement? Is it something that restricts their access to other people? Is it something that restricts their access to locations? Is it something that prevents them from being able to do things they want to do or be able to have things they want to have? So, for example, if somebody has limited access to a phone or not access at all, that would be a restriction. Does it restrict their rights in any other way? And does it employ aversive methods? If the answer to any of those questions is yes, then this is a restrictive intervention. So seclusion timeout is an example of something that's both a reactive strategy and a rights restriction. Using a response cost, fines, making somebody pay restitution after damaging something is also a restrictive intervention. As I mentioned, prohibiting phone use or limiting its use is restrictive. If you're limiting somebody's ability to go in the community or you're delaying it after something has happened, that's a restrictive intervention as well. If you limit the amount of money somebody can keep, that's also a restrictive intervention. So talking about rights restrictions or somebody's limitations or limitations of a person's rights, these are things that you need to think about. So if you're limiting a person's general liberties that's available to any of us, so something that we would all have access to, you're limiting that, it's a rights restriction. So that might be limiting somebody's freedom of movement, limiting their choice, limiting their communication with other people, limiting their leisure activities, again, talking about money, so limiting the amount of property or money they can have at any given time, or whether they can access parts of the home or community, and limiting any of those things that are assured by the Department of Mental Health. So there's some specific ones that are laid out there. We can send a link with some good resources on that. And finally, are you promoting treating the person with respect, dignity, and trying to ensure a least restrictive environment? So if all the answers to those are yes, except for the last one, which should be a no, then you've restricted somebody's rights. So what we're most concerned about today are those things that fall in both reactive strategies and and restrictive interventions. So let me say that again. So what we're most concerned about today are the things that fall in both reactive strategies and restrictive interventions. So when those things overlap. So specifically, we're talking about reactive strategies that are restrictive, and it's important to recognize that things like emergency procedures, which is a restrictive intervention that's also a reactive strategy, require the creation and implementation of a safety crisis plan. So that would be one of those situations in which a safety crisis plan would be required. So safety crisis plan, what are those? Real quickly, it's just an individualized plan outlining what reactive strategies that are in place to most safely address somebody's dangerous behavior at the time that it happens, or to prevent it from happening in the first place. So safety crisis plans help us prevent crisis, or if crisis does happen, it gives us strategies that we decide ahead of time on that have a good chance of resolving the situation safely. We do this routinely in lots of different areas, but we usually forget about it when it comes to supporting people. We have lots of safety features and practices to reduce the chance that we have a fire in our house. And if a fire happens, we have a pre-planned and practiced route of evacuation. The fire department and EMT show up and execute a pre-planned response to help people in that situation. We have safety features in our cars. We have rules of the road, we have signs, we have road design that all aim to prevent automobile accidents. And if an accident does happen, EMT and police show up and execute a pre-planned response on how to help that situation. Factories pour tons of money into trying to avoid breakdowns, whether it be in production or design, and they're constantly looking at whether they need to redesign the physical plant, whether they need to change working conditions, whether they need to revise work schedules, whether they need to retrain people. They're constantly looking for ways to ensure that they don't have a breakdown. And if a breakdown does happen, they have a pre-planned and practiced response to minimize the breakdown and to get things moving as fast as possible. So the individuals that we support are much more important than something produced in a factory, and they can find themselves in situations that are equally as serious as a car accident or a fire. So we owe it to the people that we support, we owe it to the staff that we hire to support those individuals to have a plan in place, implement it, making sure that it's preventative, proactive, and appropriate. That's a safety crisis plan. There was a question about repeating when safety crisis plans are required. Again, when you're utilizing a reactive strategy that's also a restrictive intervention, for example, emergency procedures, that would be a situation in which a safety crisis plan would be required. There was another question about what is dangerous behavior. So dangerous behavior is anything that puts the individual or the people supporting them at risk. Yes, Dr. Rogers. Also, anybody in the community. So basically, any other person, including the person themselves, at risk. It also can mean a situation that could result in significant property destruction. I believe the directive talks about more than $200 worth of property destruction. So basically, dangerous behavior is anything that could result in injuries to another person or the person themselves, or result in significant property destruction, or something that would be considered illegal and could get them jailed or taken to the hospital. Does that answer the question that was presented? I'm hearing yes. So here are some common questions that everybody has when we talk about safety crisis plans. I imagine that most of you in the audience probably have these same questions. So we're just going to take a few moments right here just to talk about them, just because these are all just so very common. So the first one is, who's qualified to create a safety crisis plan? You don't need any special credentials to create a safety crisis plan. Any planning team can come together and write a safety crisis plan when one is indicated or required. When you're writing a safety crisis plan, you might decide or conclude that you need additional help. This would be a good time to get additional help. If a behavior provider is involved, they should have input into the plan, and they should incorporate the safety crisis plan into the behavior support plan. It is not the sole responsibility of any one person to create the plan. This means that it's not the total responsibility of the behavior analyst. It's not the total responsibility of the service coordinator. It's not the total responsibility of the residential provider to come up with the plan. The team work together. Everybody should have input into it, including the individual themselves. So who writes the plan? The simple answer to that question is anybody. It depends on the planning team. So I would suggest just deciding ahead of time who's going to write it down. It could be the service coordinator, could be the professional manager, it could be the behavior provider. It really doesn't matter. Anybody can write down the plan as long as somebody writes down the plan. Recognize that you have to incorporate the safety crisis plan into the behavior support plan if there is one, and it needs to be incorporated into the individual service plan as well. At minimum, there needs to at least be some sort of reference in the plan that it exists, but ideally the whole plan should be incorporated into the ISP. Again, it's recommended that you just decide up front. You could utilize a regular meeting when you're getting together. It could be an annual plan meeting, and just decide, hey, John, you want to write the plan? Yeah, I'll write the plan. Okay, cool. You can write the plan. Again, it doesn't have to be a special person, just as long as it gets written. Who is responsible for the plan? Everybody on the planning team is responsible for the plan. They're responsible for the creation of the plan, and they're responsible for the implementation of the plan. It's the additional responsibility of the behavior provider to incorporate the safety crisis plan into the behavior support plan. It's the additional responsibility of the service coordinator to incorporate the safety crisis plan into the ISP. But it's everybody's responsibility to ensure that the plan's created and it's implemented. Who initiates the plan? Again, the simple answer is anybody. Anybody on the planning team can request that a safety crisis plan be developed given a current situation or a history of challenging situations. A regional office can initiate a safety crisis plan based on the same criteria. And remember, recognize that once you've used a reactive strategy that is also restrictive, you have to make a safety crisis plan. So who approves the plan? The planning team that comes together to create the plan should all agree that this is the plan they want to use. The individual and the guardian, if there is a guardian, should consent to its use, but nobody else needs to, quote-unquote, sign off on it. The regional office doesn't need to review or approve it unless it's been specifically requested, for example, as part of a follow-up process for discovery of prohibited practices. That would be an instance where the regional office might want to approve it. But in general, it's just, does everybody agree to this document? If yes, then put it into place. So there's a question about whether the safety crisis plan should be a separate document. It should be incorporated into the ISP and the BSP. So if you want to have a separate document that's supposed to be kind of a tool for staff to use to help remind them, by all means, that's part of your implementation strategies. But the actual safety crisis plan needs to be part of the ISP and or the BSP. So there's another question about whether or not a safety crisis plan needs to be developed and implemented every time a rights restriction goes through due process. So what you need to think about when you have a rights restriction is how you're going to carry that out. If you're going to carry it out as a reactive strategy, so this is a reactive strategy that's also restrictive, then you would need a safety crisis plan, or how you're going to implement that rights restriction that's in a way that's least restrictive, and all those things that you're doing ahead of time to prevent the likelihood that you're going to have to use that restrictive intervention as a reactive strategy. But no, not every single rights restriction would need to have a safety crisis plan. But that's why we went through that Venn diagram of all those things you need to be thinking about on determining where this kind of falls. So again, if it's a reactive strategy, it's also restrictive, you need a safety crisis plan.
So this is Terry Rogers. There's a second part of that question that says, if we have a behavior analyst who will be working with our consumer but is not able to get to them for a period of time, what do we do in those instances, as we will need guided direction but don't want to try and implement something that could be changed? So that sounds like before the behavior analyst is involved, you need a safety crisis plan that's developed by the team. And that can eventually be changed as we see how that safety crisis plan works, or as the behavior analyst learns more information following their functional assessment. Safety crisis plans are fluid documents that should be reviewed frequently and changed when necessary.
Are there, while we're doing this section, we're talking about common questions, does anybody else have any other questions they just want to throw out about safety crisis plans? A lot of this information is probably going to be covered as we go through this, but please feel free to take time to ask the questions. There's another question. When there's already an active behavior support plan in place, we do not need a safety crisis plan in addition to the behavior support plan, correct? So the behavior support plan is not the same thing as a safety crisis plan. So if you have behavior services in place, the behavior analyst should assist the team in coming up with a safety crisis plan, which would then be incorporated into the BSP. So a BSP and a safety crisis plan are not the same thing. A BSP can have a safety crisis plan in it, but it's not the same thing.
Actually, BSP should have a safety crisis plan in it as part of the behavior support plan. What do I do when the behavior happens, the dangerous behavior happens? That's your safety crisis plan. So a BSP would have a safety crisis plan as part of it. There was another question that asked, would the BRT be the one who would give us direction then? So Tiffany, I'm not sure what then means. The BRT, the Behavior Resource Team in the regions, might be assistance for you. I'd prefer you go to the area behavior analyst if you're having a more complicated situation, because then they could guide you as to whether you need behavioral services or not. This workshop here should help you have the knowledge to write a safety crisis plan. So the BRT are not safety crisis plan writers, but they might be good assistance for you if you need universal strategy prevention level of assistance. Another question says, okay. All right, so another question is, do we need to update? Whenever you find that the strategies are not effective, you should update the plan. And so the plan should be reviewed after every crisis, I would think, to see if it worked and if it was implemented. Another question says, if we already have an individual support plan that addresses risk and teaching strategies, And then we already have a behavior support plan which addresses the crisis risk. Do we need to go backwards and complete a safety crisis plan? Okay, so that's a good question. I'm reading that question to say that the behavior support plan is only talking about how to deal with risky behaviors. So that sounds like a behavior support plan that is really just a safety crisis plan, and that's not a good behavior support plan. So a behavior support plan is going to have how to prevent, how to teach skills, how to avoid situations, which is also part of the safety crisis plan, and what to do when the dangerous behavior occurs. So that would be the part of the safety crisis plan. I think it makes it clearer for everybody if you just go ahead and label that part of any plan safety crisis plan. And that would be my strong recommendation. What your team decides to do and what works for your team depends on, are people implementing and is it really working? So I guess that's my direction on that part. Lucas, do you have anything to add?
No, that sounds adequate.
Okay.
Another question, isn't making the person pay for damages natural consequences instead of a restriction? Can be both, I think.
So, right. Sometimes we are requiring people to pay for things that they'll never in their whole lifetime of whatever money they possibly have access to ever pay back, which is unreasonable. And that's why Centers for Medicaid Services calls it restriction, because you're taking away their money. Doesn't mean you can't do it. It just means you need to treat it like a restriction.
Do we need a crisis plan each time behavior occurs that results in a restrictive intervention? That would be an indicator that you need a plan. So the plan should be comprehensive and cover all the different behaviors that might occur, and we'll talk about that more in a minute. But yeah, you need a plan in that case. And there's a question about an example of a restriction that uses a reactive strategy. Emergency procedures. So a MANT or a CPI hold would be a restrictive intervention that's also a reactive strategy. A restrictive intervention that's not a reactive strategy would be just putting everybody in your house on an 1,800 calorie diet because you want to make sure everybody's healthy. You're restricting them, but it's not necessarily in reaction to something that somebody's doing. You're just going ahead of time and just putting everybody on an 1,800 calorie diet because you want to promote health and good weight.
We're not recommending that.
No, that's just an example. Does this apply only to clients of DMH? If the individual you're supporting, so let me step back. So these recommendations are good for people. So if you're a human being, these recommendations make sense. However, they are really important to consider if you're supporting an individual who's being funded through CMS, so that's Medicaid or Medicaid waiver. There is a template that will be discussed later, so I'll leave that one there. What is the criterion in which something is judged to be unsuccessful or not working? So if you have a plan and you carry it out and the person still ends up in a restraint or at the hospital or the cops have been called or somebody's injured or something is broken, that would be a good indicator that it didn't work and you should make changes. I'm not going to talk about landlords and repairing damages done by the client. That's kind of outside the scope of what we're going to talk about today. So I'm going to go ahead and switch back to the presentation now because it seems like we've exhausted the relevant questions. And we can circle back around, or you can contact me directly, and I'd be happy to kind of continue to talk through some of these things. But let's go ahead and get to the rest of the presentation, and you might find that some of these questions have been answered. So I keep saying planning team. So who is that? We probably all know that, but I'm going to talk about it anyway, just in case some people don't know. But it's anybody that supports the individual and has an interest in seeing the person do well. This means the person too. So all those people that come together and support the person. The planning team may be big, it may be small. There's no standard size for a planning team. It really depends on how many paid services are in place and how many unpaid or natural supports the person has. Some common participants in a planning team would be the individual, obviously, because it's their team, direct care staff that work with the person. These people are incredibly important because they spend most of the time with the person and have a lot of good input on what might work and what might not work when you're talking about what to do. The house, the professional manager, as the supervisors of the direct care staff are good participants to have in a planning team, as are the agency director or the owner. The reason why it's important to have agency directors or owners or administrators as part of the planning team because they have the actual power to ensure things are being implemented correctly. Outside of the contracted residential provider agency, you have the support coordinator who must be a part of the planning team. You also have a guardian. If the person has a legal guardian, they must be a part of the planning team. The behavior provider, if there is one, can be a part of the planning team. So too can a person-centered consultant, a counselor, ideally also the psychiatrist and the primary care doctor. These are all people that can and should be a part of the planning team. The key is to make sure we're fostering collaboration among many people that are involved in the person's care. So nobody should be working by themselves. We shouldn't be working in silos. We should be working as a team. One of the reasons why it's so important to work as a team is to make sure that we don't have competing or conflicting goals, so that one group of people aren't doing something that conflicts with somebody else's goals. And it's also crucial when we're talking about crisis that everybody does the same thing or has the same awareness of what the situation is. So let's talk a little bit about what makes a crisis. So we're going to talk about all the different factors that kind of come together to make a crisis situation. So when we think of crisis, we typically think of those acute things that seem to come out of nowhere. Things that we could have never prevented no matter how much planning happened. You know, these are what we're thinking about. It could be like a serious illness like pneumonia or cancer. It could be a radical change in the environment, such as the death of a family member or a staff person leaving. And we also a lot of times lump in, quote-unquote psychotic events in this category. And it may be true that some things really are unforeseeable, but what we will find out as we kind of go through this is there's a lot of quality of life, everyday issues that contribute to these kind of acute, serious situations like illness, psychotic events, and turnover in staff. And it's really easy to see how these acute things can create a crisis for a person. They would create a crisis for anybody. They are significant and sudden worsenings for the person. However, a crisis doesn't have to be that intense for any of us. So it doesn't have to be cancer. It might be as mundane as a flat tire on your way to work. It could be spilling your coffee first thing in the morning. Like right before you had a chance to drink any of it and kind of wake up. It could be missing the bus. It could be a missed opportunity. It could be lots of little things that contribute to having a bad day. So if you ever started your day off, an alarm didn't go off, so you got up late, and you could never seem to catch up for like the rest of the day, it's one of those days where you have trouble keeping a positive attitude in which you struggle to kind of keep your composure, and just every little thing seems to kind of bring out kind of a huge response to you. So everything is a huge aggravation, even the smallest things. What we a lot of times don't realize is that the individuals that we support have these same sort of everyday issues that come up that kind of put them in a situation to have a bad day, just like any other human being. We also don't realize a lot of these things that we're going to talk about now. So even a lot of these are long-standing issues that contribute to recurring episodes of crisis or the so-called crisis cycle. So a lot of times there's a history of inconsistent implementation strategies that have already been identified. So these are things that we know we're supposed to be doing, but we don't do them very well. So we have a tendency when we're training staff to do strategies to hand them a piece of paper, have them read it, and call that training. We also have to recognize that staff rollover is a constant issue. So people change jobs quite frequently. So it's highly likely that at any given moment we have somebody that's inexperienced working with the individual. So bottom line, we don't really know what we've actually been doing. We don't know what is and what is not working. So that's a huge issue that's commonplace that kind of contributes to reoccurring crisis. Another thing is when we actually have strategies that we are implementing effectively, or we're actually implementing consistently, they're typically not effective because they're not specific to the person, but instead they're kind of programmatic or across the board. We do them with everybody, and we don't have specific ways in which we're using it for that person. A lot of times these strategies are overly restrictive, and we have a tendency to start off with the most restrictive intervention rather than the least restrictive. For example, somebody gets in a physical altercation with their roommate, and now they're one-to-one 24 hours a day within arm's reach. So starting with the most restrictive response as opposed to something less restrictive. There may just be inefficient resources to help support this person. So even if it's identified that they need these things, that we may not have access to them. There may not be transportation available to get the person to where they need to go. There may not be behavior service providers, even though we recognize they need them. There may not be vocational resources. There may not be person-centered strategies available. There may not be day service providers in the area. There just may not be stuff that the person needs. Consequently, these are things that are really important to consider when somebody's transitioning from one place to another. Does the place that is the proposed new residential provider actually have the capacity and the access to resources that the person really needs? Sometimes people have medical problems that, if they're not treated or unresolved or are not identified, cause worsening situations for the person. We know that individuals that have disabilities have a higher incidence of medical problems by virtue of their biology and also difficulties in communicating about symptoms. So things like constipation, digestive issues, dehydration, thyroid problems, diabetes, arthritis, blood pressure issues, seizure disorders, eyesight, the list can go on for a really long time. The bottom line is that when you have unresolved medical problems, it creates a worsening for the person, and it contributes to challenging behaviors for all of us. This is not specific to individuals with developmental disabilities. This is specific to human beings. When you add in difficulties with communicating and a general lack of self-control skills that we all take for granted, you get a recipe for an easily preventable crisis. Medication is also something that is overlooked. So there may be too much or too little or the wrong medication. As a population, people with developmental disabilities are highly medicated. Some of this is a kind of a product of the fact that they tend to have more medical problems. However, some of the medication is used to help control psychiatric conditions or just to control behavior. Psychotropic medications as a class of drugs carry with them a large host of serious side effects that should be monitored closely. A lot of times we don't recognize that the people that we support typically have poor social relationships within the home, including with their roommate, could be staff paid to support them. They also don't have a lot of good relationships with people in the community, or any at all. So they aren't having too many positive social experiences in their day-to-day life. Instead, they probably are having a lot of frequent negative social experiences in their day-to-day life. So they aren't being recognized when they're doing healthy and desirable behaviors, those things that we want them to do more of, and they're really only being recognized when they do the things that we don't want them to do, so those unhealthy and those undesirable things. And they have little to no natural supports to lean on. They probably feel isolated and lonely, and they might feel like nobody cares about them. And they might not have a meaningful day. So a lot of times people that we support don't have a lot of things going on in their life that we would consider meaningful or that add value. So they have little choice over what they do on a day-to-day basis, and they also have little choice of what their life direction looks like. They might be bored. They feel like they have no say in what their life looks like. There are not a lot of good things going on. They might want to work and be capable of working in competitive employment, but they're told they must go to a day program, or they're too unpredictable to work, don't understand how to work, or will just change their mind and quit. So let's look at a crisis that might occur for an individual we support. So we talked a lot about all those different things that we sometimes can recognize and sometimes overlook that contribute to crisis. So let's kind of look at an example of one day for Donnie. So we'll start off with argument with a housemate. So it's hard to live together with another person. It's even harder when we haven't chosen to live with the person that we're living with. So Donnie, for this example, and his housemate are in an argument over where they want to go in the afternoon. Donnie wants to go to the local soccer game, but his housemate would rather go shopping at the mall. So Donnie gets mad. He slams his bedroom door and shoves his mattress off the box spring. After 15 minutes of shouting at each other, Donnie's housemate agrees to go with Donnie to the soccer game if they can get Chinese food at the mall afterwards. So they make up. So now we're kind of coming back down. However, the direct care staff's payday is still a few days away, and staff doesn't have the money to put gas in their car to take them out. And they don't have access to a company vehicle. So Donnie and his housemate are understandably crushed by this. So the staff suggests that maybe they can stay at home and watch TV. There's this new show Donnie's been talking about that he wanted to see. It's called Marvel's The Defenders. Maybe you've heard of it. And Donnie and his housemate decide, yeah, we'll do that. Let's sit down and watch that. So after the show's over, they sat, they enjoyed it. Donnie and his housemate get in an argument over which character was the toughest and the coolest. Donnie thinks that it's obviously Luke Cage, but his housemate thinks that Daredevil is way cooler. So Donnie threatens to break the TV and beat his housemate with the pieces. So staff person comes up, he empathizes with both of them, recognizes that each one of their characters is really cool, and suggests that in the past, going for a walk has helped Donnie feel better. So he says, hey Donnie, I know in the past it's worked really good for you, do you want to try it? Donnie says, yeah. And he decides to take a walk around the block and come straight back. So then shift change happens. Night staff comes in, and while this staff generally has a good relationship with both Donnie and his housemate, the staff person's had a bad start to his day. So his kid's sick, he's just got an unexpected bill that he can't afford, so he's in a bad spot. He finds out that Donnie and his housemate have been having trouble over the TV, so he sits him down on the couch and says, hey, I heard you guys have been bickering over the TV today. Tell you what, if any of that stuff happens tonight, I'll take the remote and nobody will watch TV. You guys got it? So the night staff realizes, hey, maybe I was a little harsh, and I feel kind of bad about that. So he makes sure to check in with both frequently to make sure things are going okay. He reminds Donnie that, hey, tonight's your laundry night. This is when you typically do it. Do you want to do it? Donnie says, cool, I'll do that. So he goes he goes to the washer, but his housemate has left his stuff in there. It's soured. It's kind of damp. He gets really mad and begins yelling at his housemate. He grabs the clothes out and throws them on the floor. His housemate comes in and grabs Donnie's hand, yells at him to stop throwing his stuff around, so Donnie punches him in the face. The next morning, the planning team meets to decide what they're going to do, and they decide that given Donnie's frequent outbursts and his escalating behavior, that he will need to be one-to-one within arm's reach 24 hours per day. They further decide that he's probably not safe to go out in the community for a while because he's so unpredictable. Keep in mind, we just walked through one day for Donnie. So these are the things that highlight all those kind of unresolved, long-standing issues that contribute to crisis situations. So what do we do? With so many factors, it's got to seem overwhelming for anybody involved. So taking a look at the elements of the cycle helps us understand how to make a plan. So what we want to look at first is the bottom, the stable, typical functioning. This is where we want people to be. It looks like things going well. It looks like low stress and lots of positive things going on. This is where we want people to be most of the time. When you look towards the middle of the graphic, escalating means things are getting stressful or worse for the person. They're on a path to become out of control. This is where we want to turn things around. So similarly, when things are de-escalating, they may be moving in the right direction, which is back towards the typical stable functioning, but things are still really tense and could escalate again really quickly and without a lot of frequent positive support from staff. And when things have gone to the peak, so that's the top of the graphic,
this is when things are out of control. So we want to avoid these situations as much as possible, because there's nothing we can do except maintain the immediate safety of everybody involved until the person starts to come down and starts to de-escalate and gives us an opportunity to start working with them again. An individual crisis event can last from a few minutes to many hours. So it's going to be crucial that we try to figure out where the individual falls on this kind of span of possibilities so that we can plan appropriate supports for them. So is this something that we're going to need to do for a little while? Is this something we're going to need to do for a long time? So being able to figure that out ahead of time. So our goal is make sure that the peaks and valleys are less extreme. So if you look at the very top and you think back to our example on Donnie, making the distance between those escalated moments and the calm moments less extreme, so they spend most of their time at or near the stable functioning. And making the peaks and valleys last less time, so making sure that if they are happening, they resolve more quickly, and also that they happen further and further apart. And we do this by giving the individual skills. So having skills makes the individual much more resistant to those common everyday stressors that we all face, and it gives them something positive to do when an unforeseen crisis event actually occurs. And this allows them to more confidently and competently interact with their environment. So what do? Well, we plan and we prevent. In order to plan, prevent, and appropriately respond to a crisis situation, we've got to figure out the answer to the following questions. So think about these as we go through this. How can we change the environment to support that stable, typical functioning and prevent the escalating phase from reaching that out-of-control phase? If it does get to the out-of-control phase, what do? How do we keep everybody safe? And then how do we support an individual when they're starting to kind of come back down and de-escalate to help them come back to that stable, typical functioning as quickly as possible? So as we're thinking about those questions, let's look at kind of what promotes somebody staying at the stable, typical functioning. We always want to rule out medical issues first. So unresolved medical problems create a worsening for the person, and they contribute to challenging behaviors. Again, this is for all of us. This isn't just for an individual with developmental disabilities. However, for somebody who might have trouble communicating when they're in distress, it becomes even more serious and more important for us to make sure that we're looking into medical issues first. It's also really common for individuals that we support to be on lots of medications, which further adds some medical components that we need to be thinking about. Basically, any behavior challenge a person can produce or show us could be a manifestation or could be a result of a medical concern. And while it's not necessarily simple to fix, resolving medical issues typically significantly improves the individual's life, or at the very least doesn't make it worse by making environmental changes that may not be necessary. This is why it's crucial that we resolve medical conditions first. So some common examples. Constipation has been shown to be related to aggression or lethargy. Dehydration can make people seem confused or loopy. Thyroid issues can look like things we might describe as anxious or agitated or depressed. Common aches and pains, like people with lower back problems or headaches or joint pain, might make people less patient or easily angered. Issues with eyesight or hearing may be related to exaggerated startle responses, troubles communicating, and following conversations or directions. Seizure disorders have been shown to be related to aggression. Things like urinary tract infections, when severe, can produce things that look like what you might call psychosis or psychotic behavior. Now, I'm not a doctor. You're probably not a doctor either. The point is not to diagnose the person's medical problems. The point is to recognize that medical concerns cause or contribute to challenging behaviors, and they should be ruled out first. When challenges are occurring, we should be looking for updated medical checks. That might be blood work, it might be testing, but we should be taking them to a primary care doctor or ensuring they have a current medical workup. We may also want to get a medication consult with the primary psychiatrist or whoever's prescribing the medication to ensure that what they're taking is the most effective, least amount that they would need to be successfully supported. And we should also not forget about other disciplines like dentists and orthopedists or hearing people, all those other specialties that can help us identify if there's medical challenges. Again, when we overlook medical problems, we create a recipe for an easily preventable crisis situation. Now, I know this doesn't look like it goes together because you have a stick figure beating another stick figure next to the word stable, typical functioning, but bear with me. Another frequently overlooked thing about individuals that we support is past trauma or abuse. So in general, people with IDD are at a higher risk to be victims of some sort of abuse. It could be physical abuse, it could be emotional abuse, it could be sexual abuse, it could be all of it. And it's probably safe to assume that everybody that we support has experienced trauma. So the goal is to consider how this might be affecting their current situation. And again, this might look like an exaggerated startle response to being touched. It could be an extreme reaction to something that we might consider a minor situation, such as being in a smallish or a place that seems kind of enclosed, and it might result in somebody being aggressive. Could include somebody trying to avoid situations or withdraw. People might complain of being sick. They might have trouble sleeping. They might have bladder control issues. Now, I'm not a therapist. You're probably not a therapist either. So again, the goal is not to diagnose somebody, in this case with something like post-traumatic stress disorder. Instead, you're trying to consider what sort of situations or interactions seem to result in extreme responses. So you might consider how somebody reacts to being touched on the arm, on the shoulder, on their back, by somebody of the same sex or the opposite sex. So what happens when that occurs? Does the person freak out if you touch them from behind, if you touch them on the shoulder without announcing yourself? Are there specific locations that are associated with extreme behavior? So think of stuff like restrooms or closets or bedrooms. And are there specific items or features about a person that are associated with extreme behaviors? Think about seeing a rope. Think about a particular scent that seems to really produce a reaction in the person, or maybe it's a vocal tone, the way somebody speaks. Could be, excuse me, it could be maybe facial hair or a particular pattern. Again, it's just recognizing what sort of things seem to kind of happen along with the extreme situations. And if during the safety crisis planning process you think you've identified some of these factors, you should get some further help. Get somebody in there that has experience dealing with trauma or past abuse. And this could be like a counselor or a therapist or a behavior analyst can also help. So making sure you recognize that this is probably outside of your wheelhouse and you need to get some additional help. So we've considered things that might be medically wrong. We've considered trauma. Now we need to consider the person's current life situation. So what things are preventing the person from having a meaningful and an interesting day? What needs are not being met? Does the person have frequent contact with other people besides paid staff? Is the person stuck at home most of the day? Does the person have an assigned daily schedule? How much choice do they have in that daily schedule? Does the person need enough help from staff to do some of their activities of daily living, like using the bathroom? What skills could the person benefit from learning? Do they know how to start a conversation with another person? Do they know how to keep a conversation going? Those are not the same thing. Does the person know how to plan their day? Have they had the opportunity to make choices? Have they been taught to use the bathroom? To clean themselves? Can the person learn to dress themselves? Typically, if you can identify an unmet need, it suggests a skills deficit. And if you can identify a skills deficit, you can see how that contributes to a need not being met. If the person doesn't have contact with people outside of paid staff, they may not know how to talk to people. And if they haven't been taught conversation skills and have the opportunity to practice them, we might not think they're ready to be in those situations. And they may avoid them, or both. The key to this step is to recognize that these are universal, which means that everybody needs to have them in place to have a good life. This is the base of our pyramid, and it's the foundation where we build everything on top of. The bottom line is that the greater the quality of life a person has, the lower the chance that they will display challenging behavior or fall into a crisis cycle. There are a lot of services available to help meet the needs of somebody with these skills deficits or unmet needs. So consider what things could be tapped in to support the person that might help support what you're already doing. This might be person-centered strategist consultants, PCSC. It might be community integration. Could be employment training or opportunities. It might be a day program or a day center. It could be community mental health center or a counselor. It could be personal assistant. It could be assistive technology. It could be behavior services. It could be a lot of things. Just recognizing that there are already services available that you can tap into. So recognizing, do you need them, and then figuring out how you can get them in place. So finally, when we're talking about promoting stable, typical functioning, we need to think about what staff are doing on a day-to-day basis. So what are they doing to help the person have a good quality of life? So all providers that contract with the Division of DD are required to train staff in positive behavior support, PBS. And they should have some sort of organizational PBS policy. The last consideration then is to make sure that staff are actually applying this training and philosophy in a way that works for the individual. So again, it's not enough to train somebody. You need to make sure they're actually doing it most or all the time. So if tools of choice is your PBS curriculum at your organization, you know that Stay Close Cool is one of the tools that you can use. So how do you use this with the individual? How do you stay close with this person? What does that look like? Is it a pat on the shoulder? Is it a high five? Is it a head nod? What sort of things do you say to the person to let you know that you're empathizing with them? How do you validate their feelings? What things are is the person working towards that you can use when you're providing encouragement? If your organization doesn't use tools and they use another curriculum, how do you apply that to build a relationship with the person and to increase their quality of life? How do you notice and support all those things that they're doing that we want them to do more of, those healthy and those desirable behaviors? Once you figure that out, the next question is, are staff doing it most or all the time? The key to remember is that environments that support and richly reward healthy, desirable behaviors have less behavior challenges. So if we can ensure that all components that contribute to stable, typical functioning are in place, then we will have little or no crisis situations. This is really what we want. If we put our effort into the front end, we can prevent having to react in a crisis situation. Furthermore, if we have a crisis situation that comes up that we really couldn't have prevented, an individual is going to be much more likely to be successful in handling that unforeseen situation because they're not also dealing with a laundry list of other issues. So moving on to away from stable, typical functioning to now we're moving kind of up the curve to escalation. We kind of have a good idea now, or we should have a good idea of what the person needs to have an interesting and meaningful day. All those things that we can do to prevent a crisis situation. So now we need to consider what makes the situation worse. What are those things that create worsening for the person? We call these things trigger situations, and we want to steer clear of them as much as possible. Things that might be a trigger situation really depend on the person, and it could be things like early morning, lack of sleep, tight spaces, seeing a particular restaurant like McDonald's or Arby's, being approached from behind, loud noises. Again, it can be anything. And it might change depending on where you're at. So it might change depending on whether you're at home or whether you're at a doctor's office, whether you're out in the community. The key is to discover which things make a worsening for the person. So an example of a guy I used to work with, for him, given his trauma and kind of abuse history and kind of where he grew up, typically in institutions, if you walked up behind him and touched him on the back, he would turn around and punch you in the face. So that was something we identified as we should probably avoid doing that. Which seems kind of self-explanatory and really simple, but sometimes we don't stop and think and have those sorts of discussions about some simple changes that we can do. Like, hey, you never walk up behind Johnny without announcing yourself, and you never touch him from behind. We also need to think about what the person can do that might let us know that they're getting upset or that they're having trouble coping with the situation they're in. So we all have different ways of communicating this. We all have different things that we do to show others that we're angry, that we're sad, that we're hurt, whatever it might be. It might look like clenched fists. Some people talk faster. Some people get louder when they're upset or when they're excited. It might look like somebody talking slower. Some people talk more softly when they get upset. Some people walk away from other people. Some people seek people out. It could look like a blank stare or no facial features. The person's face might become wrinkled in a scowl. Again, it really could be anything. The key is to try to figure out how the individual communicates that they're upset, not just in words, but also in body language. It's being able to identify these are the crucial first steps in deciding how we're going to respond to these challenging situations. We also need to consider these two more questions when we're thinking about this initial phase of escalation. How long has the person stayed upset in the past? Is this somebody who kind of blows up and is quickly over it and goes on with the rest of their day? Is this somebody who kind of stews on something that's happened for a long time and then blows up, or gets upset and stays upset for a really long time? So how long do they stay upset? A few minutes, hours, days? We need to know what this is so that we can make appropriate plans. How long is the longest an episode of dangerous behavior or a crisis situation lasted? So how long has a person been in crisis? So understanding what the answers to these questions are going to help us know how much support we need to put in place and for how long. And don't forget the person. So the person is the best reporter of their own experience, and they should have a part in this process because they know what they like and what they don't like. And so we might just ask them, hey, what do you like to happen when you get upset? Some people like a shoulder to cry on. Some people like space. So what would they prefer to happen in a challenging situation when they're upset? What would they prefer staff to do? What would they prefer staff to not do in a challenging situation? So we need to know what they want to have happen. We also need to know what they don't want to have happen. So they might be very sensitive to being crowded, or they might not like being surrounded by one or more people, even if those people are backed off. Or they might not like to be touched. They might like a shoulder to cry on. They might not like to be called nicknames. So maybe they're cool with having nicknames sometimes, and that's a good way that you build your relationship, but when they're upset, they hate being called nicknames. So making sure that you know what the person wants in that situation, what they don't want. If communication is a barrier, then we need to try to figure out what they're trying to tell us and recognize that this is where we need to be putting all of our effort in. We need to be building up their ability to communicate. So we need to be getting extra help, whether it's through some sort of assistive technology, additional consultation for some teaching strategies, but we need to understand that when you can't communicate, that is frequently going to result in a problem situation because that is the only way that over time they have been able to successfully have their needs kind of be met. And I think we can all recognize that when we aren't able to effectively communicate what we're trying to say, how frustrating that is and how that could lead to kind of a challenging situation. So we've looked at what creates a worsening for the person. We know what they look like when they're upset. So now we need to consider what we've done in the past. And we need to figure out whether that has worked or not. So first, the question to ask is, what do we do? Do we even know what we did? And if we do know what we did, was it effective? And again, to tie back to that question earlier, if stuff results in law enforcement contact or somebody getting hurt or somebody going to hospital or somebody having to be restrained, that's a pretty safe bet that that was not an effective strategy. The strategies that we've used in the past, were they done faithfully? And that means that everybody did them the same way most or all the time. So we need to figure out that. We need to take the strategies that have worked in the past, or those things that we have implemented with faithfully that have worked, and make sure those are part of the safety crisis plan. So we wouldn't want to take away a strategy that's helpful. We just want to make sure we get that documented and ensure staff are always doing that. And if we recognize that we've done some stuff in the past, some strategies that didn't work out, we know we did them right, we need to make sure that we don't do those again. So if we have strategies that haven't worked in the past, we shouldn't continue to do those. We should also consider whether the person has relaxation skills or coping strategies that we could incorporate into the safety crisis plan. So first we need to figure out what they are. And then we need to figure out how we can promote their use in a challenging situation. We need to think about if there's an event that might prevent or interrupt a situation from escalating. Maybe that's a talk with a person. Maybe it's the availability of music or space. Some people like to call loved ones or friends. Some people go on a walk. Some people listen to music. So when we have this knowledge, how do we use that to successfully resolve a crisis situation or an escalated situation? What can we do to help this person successfully manage the situation without getting to that out-of-control peak? And finally, most PBS curricula, and probably all, have strategies to help an individual de-escalate. So what's your agency strategies? Do you guys use tools of choice? Is it something else? Figuring that out, what is the strategy that we're supposed to use? And then asking the question is, are the people that have daily contact with the person, so this is direct care staff and everybody else that has daily contact, are they using those strategies consistently, the same way, every time? So for tools agencies, that means asking the question of whether or not staff are using stay close hot, along with stay close cool on the front end during escalated situations. It's important that staff are confident in actually applying these general strategies in a way that's specific to the person. So knowing what stay close hot, if you use tools, looks like for the person. Knowing what sort of empathy statements are going to be most effective for that person. Knowing what sort of coping strategies that they've used in the past and how to suggest those in a way that doesn't sound like a command and sounds more like a suggestion. And being empathetic and avoiding using language that's coercive or harsh or demanding. So we've spent most of the time talking about how everybody's different, so it's important that staff that are supporting the individuals recognize what's unique about this person and how do I successfully support them in a challenging situation. So here, we weren't successful at de-escalating something, and now we're at the out-of-control peak. So at this point, we're really only concerned about maintaining safety and getting out of this out-of-control peak as quickly as possible. We're probably going to use physical crisis management in this situation, so it's crucial that staff that are working with the individual are trained and certified in its use. So it's important to note that the expectation from the Division of DD is that if you're working with an individual that has a history of needing physical crisis management, that staff are trained and certified in its use. So that means if you're supporting somebody who in the past or currently is engaging in severe physical aggression or significant property destruction or significant self-injury, and it is a situation that seems to necessitate some sort of physical crisis management, the expectation is that staff actually have that training and are certified, and the agency has it on their contract as being able to offer that support for the person. It's really important to think about when you're using physical crisis management, whether the person is healthy enough and what things should be considered use or no use. So does the person have brittle bones? Do they have joint injuries or range of motion problems that would kind of let us know that we can't use certain techniques, or whether or not we should use any physical techniques? If the person has PRN psychotropic medication that has been prescribed, what sort of reactions can we expect with the use of this medication? So not just what's the intended effect, which we need to know that, but what are some unintended effects that might occur? How will they know if the person has an adverse reaction? What would that look like? What about the physical effects of the escalation itself? So does the person have a blood pressure issue? Do they have asthma? Do they have breathing problems? What does the stress of becoming escalated to the point of being out of control have on that person's body? So what might that do to the person? Do they take medication? So not as a PRN, but just in general that makes it hard for them to cool down. And how do we recognize that, and how do we plan for that? Do they have a history of contact with the police, with hospitals, or being restrained that might affect whether or not we would or wouldn't use it in this situation? So being able to think about all these things help us figure out how we're going to respond in a way that maintains safety. So at this point, again, I want to make it clear when we're in the out-of-control phase, we're not trying to teach people, we're not trying to coach them, we're not trying to de-escalate them. We're simply trying to get them through this moment, this out-of-control moment, as quickly and as safely as possible. And then we need to recognize how staff can identify when the out-of-control moment is past and they should resume de-escalation strategies, which we just talked about. So do we have questions at this point about kind of the elements that go into a safety crisis plan, or specific parts like the de-escalation phase and physical crisis management? What do you guys have questions about?
So my response to when would you expire is, why do you need to? I'm not sure why we're worried about that.
Yeah.
So that's why I don't want it. Yeah. Okay. All right.
Okay, so it doesn't look like we have any questions about what we just talked about. Recognize that if at any point later today or the rest of the week or the rest of your life, if you have questions, you can always ask me. My contact information will be on the last slide, and you can probably get that included in the blurb that goes out after this. And feel free to reach out to me or one of my counterparts. That's a great question about whether we'll be providing an example of the safety crisis plan. We're actually just getting ready to talk about, somebody asked the question whether the division would be supplying a template for use, and we're going to talk about a template that's been created, and we're going to walk through all the components of that here in a second. So a question has come in that it looks like they're asking if they're locking somebody's food up, which is a rights restriction due to a choking issue, and then the individual needs to be monitored. Is that a safety crisis plan? So that's not a safety crisis plan, but how you implement that restriction may be a safety crisis plan. So let's think about this. So where it becomes kind of a safety crisis, or comes into a territory where you might need a safety crisis plan, is when you think about how you're going to enforce this restriction. So what do you do if the person is trying to access food that has been restricted for whatever reason? And we're not going to talk about we're not going to talk about the restriction. We're just going to talk about how do you carry it out. What are staff supposed to be doing if the individual is trying to rip the cabinets off to get to the food, or if somebody forgot to lock the cabinet and they've got the food in their hand, or if you're out in public and they're trying to get to food that they're not supposed to have. So if you have responses that staff have to do that are restrictive, which these are, then you would need a safety crisis plan. And if you think about it, all it is laying out what you want staff to do to help successfully resolve the situation. It's not something special. In fact, staff probably already have an idea of what they're going to do. What you're helping them and the individual and everybody else that works with that person is by writing it down so that this is knowledge that is shared between everybody, and so everybody does it the same way. So recognizing that somebody might have a good strategy, but how do we get everybody doing that? Somebody might do something that makes it worse. How do we keep people from falling into that same trap? So yeah, that would be the safety practice plan. So a lot of times when you're talking about rights restrictions, where you get into a situation where you might need a safety crisis plan is how do you carry out that restriction? How do you enforce it? And if it involves situations where you're reacting to a challenging behavior related to the restriction, that's probably going to need a safety crisis plan. Doesn't look like there are any other questions on that, so I will go into the next section. Again, if you have more questions, just shoot them out and I will address them as they come in. So we're going to look at how we put it all together now. So the directive has a sample format that's included. It's attachment B. So we're going to walk through that form, but recognize that it's not the official form, it's not the approved form, it's not the only form, it's just an example of what a safety crisis plan could look like. It's a pretty good example. It has all the elements. If you want to use it, please do. You don't have to. You can use your own format as long as it has all the elements that we've been talking about. But this is the one that's been created and included, and so we're going to talk about all the specific parts of it so you have a good working knowledge of how to use it. So again, you can find this at the end of the directive. Again, that's Directive 4.300. The safety crisis plan example is attachment B. Attachment A is a safety assessment guide that kind of goes through all those things we just spent time talking about. And so together it gives you a good toolbox along with this training to be able to come up with a safety crisis plan. So the first section is just basic demographic information that's part of really any plan you've ever made about anything. That includes the person's name, when you developed it, so the date that the plan was made, and who participated in the development. The legal guardian has to consent to the use of the safety crisis plan, so should the individual. The individual should be involved in this plan. Now, a lot of times people have questions about, or concerns, I should say, about letting the individual be involved in the development of the safety crisis plan. My response or my suggestion is that it's an extremely good idea to have the individual involved in safety crisis planning, even if it is going to be a difficult conversation for a couple reasons. One, it's their plan. They have valuable input on what they want to happen and what they don't want to happen in a crisis situation. It would be very good of us to listen to that. It also gives them ownership of the plan. They helped create it. It's their plan. It's not something that staff are doing to them. It's something staff are doing with them. It's their plan. They're much more likely to go along with it because it's their plan if they participated in it, rather than us doing it in secret and kind of using it on them. So it's much more likely to be effective if the person participates and consents. It also doesn't put staff in a position to be doing something to the person. It's the staff supporting the person in the way the person wants to be supported. The next part of the form is the needs statement. So this lets us know or describes why you need this safety crisis plan. Why is it medically necessary? Here, just describe the most severe episode of whatever has been occurring, and this provides justification as to why this plan is being put into place. It's just something that we need to have for any service that we're utilizing for an individual within the Medicaid waiver and CMS, is that things have to be done because they're necessary, not just because we want to. So we have to indicate here why it's necessary. This is really easy. If Donnie punched out his housemate and chipped a tooth, that's a pretty good justification for needing a safety crisis plan. It doesn't have to be something super elaborate. It can be just a description of the most serious situation that's happened recently. Next, we want to have a goal for our safety crisis plan. So what does this plan hope to achieve? This should be stated positively. So how is this going to help them have a higher quality of life? So it might be something like Johnny will participate in a meaningful day while refraining from physical aggression and property destruction, and also increasing his ability to, exercise more control over his day, or engage in activities that he finds really valuable. So, how is this plan helping Johnny, Timmy, Donnie, whoever, helping them have a good quality of life, and how is it helping staff support the person to stay in that stable, typical functioning, or help staff kind of de-escalate a situation that's challenging, and it's also going to lay out what staff are going to do in an out-of-control situation. The next section is, what was the assessment for this plan? What things were reviewed? Who was interviewed? This gives us a good rule of thumb as to whether or not we need extra help. So this section does two things. So it lets us know kind of what our process was for coming up with this plan, so what things we looked at, and also, at least on this template, gives us a kind of a rule of thumb of when we might need some extra help. So if you've had to use this plan 2 times in a single month or 3 times in a quarter, so basically more than once a month, you probably need extra help. So recognizing, now that this is just a rule of thumb, but just recognizing that, you might need additional help beyond what you have available right now. Now we have got to identify what the problem behavior is. So what's the challenging behavior that this plan has been created to address? You need to define it in a way that somebody can recognize it and record it. And not just recognize and record it, but agree upon whether it happened or whether it didn't happen. So the idea is that 2 people can see the same thing and recognize that something either did happen or didn't happen. So a lot of times people say things like physical aggression. But without some definition that goes along with that, that's really vague, and it's hard to kind of implement strategies related to physical aggression because people might have different ideas about what is physically aggressive. Is somebody moving towards you in a fast manner considered aggressive? Is throwing a paper cup that's wadded up aggressive? Is somebody punching in the face aggressive? For me, personally, only the last one I would consider to be aggressive, but it really depends on how you define what you're working on in a way that can be recognized when other people are looking at this plan. So it's much better described kind of what it looks like. So what, for example, the aggression looks like. So hitting somebody or attempting to hit somebody with their hands and their feet results in a red mark on the skin of the person being hit. So specific things that's happening might last for 30 seconds. It might last for 15 minutes. It might be a really quick, intense thing that's over. So putting down something that people can read and get some training on and recognize when they see it happening kind of on their day-to-day, so they know what to do. So that's a specific challenging behavior that we're working on trying to avoid or put supports in to minimize the chances that it happens. Now we need to think about all those things that might, quote unquote, trigger the person. So we've talked, this is just those things that we talked about in the beginning section of de-escalation, all those things that create a worsening for the person. So listing them out here helps remind us of all those things we're trying to avoid or minimize during the day. It also gives us kind of a list of things that we need to make sure that we address when we get further along in the plan. So now we need to talk about what the person looks like when they're upset. So we talked about things, we've listed out things that create a worsening for the person. Now we need to describe what the person looks like or what things they might do that gives us an indication that they're upset or they're struggling to cope or that out of control serious behavior is kind of imminent or soon to happen afterwards. So this helps us visualize how do we know that this situation is escalating. Okay, so those are all of the pieces that we need to start thinking about what we're going to do. So the last part that we need to think about is what we've done in the past. And again, we've already talked about this as we went through this, but here you're just kind of listing it out. Again, having this sort of conversation and going through what has been done in the past generates some suggestions about what we can do in the future. So what has been helpful? So like an individual threatened a staff person, the staff person pivoted to something on TV and then back to the individual, following a request for help, and things de-escalated really quickly. It might also reveal a strategy that might actually make the problem worse, and so we should avoid it. So the individual, for example, threatened a staff person. A staff person explained to the individual that threatening was not okay and that it could have bad consequences if they were out in public, such as cops being called. And this resulted in the individual getting even more upset and the cops having to be called. So that would be a strategy we would want to avoid in the future. So these are things that would be helpful, that if have worked in the past would be helpful if we incorporate into the plan. And these are things that that they haven't been helpful are going to be discarded or not included in the plan. So these kind of help us map out kind of what work's already been done in safety crisis planning. So now we have to figure out what we're going to do. This is our action steps phase. Now recognize prevention is in a box there, and so this is all stuff that we're doing to prevent things from becoming out of control. So we haven't got to what we're going to do when things go out of control. Right now we're just trying to prevent it from getting there in the first place. So we've already just talked about or listed out all those triggers for the person, those things that create a worsening. So now we need to figure out what we're going to do when one of those trigger events occurs or is likely to occur. So we want to describe what needs to happen to address it. So what specifically are we going to do to either prevent it from happening, to respond to it if it happens, and who's going to do it? So specifically, who's going to do it? Is it a direct care staff person who's responsible for doing it? Is the professional manager responsible for doing it? And then how long, how much of it, how often should they be doing it? So specifically, is this something that should be done once? Is this something that should be done constantly? Is this something that should be done every 15 minutes throughout the day? How do they know how much of this they need to do? So, for example, if the trigger event is an early morning appointment, then the action to take might be to make sure that appointments are scheduled in the afternoon. This might be the responsibility of the house manager, and it should be done whenever possible. If it's not possible to schedule the appointment for the afternoon, then staff should talk with Donnie, we're using Donnie again, about whether he wants coffee from Starbucks before or after the appointment. And if Donnie decides he'd rather get breakfast at McDonald's, then staff should enter that request. And they should allow him to choose the order, appointment then breakfast, or breakfast then appointment. And the direct care staff are responsible for doing this. So that's an example of what to do to prevent a trigger event from occurring and what to do to respond when a trigger event has occurred. Next, we talk about precursor behavior. So these are, again, are those things that let us know that we're on the path towards out of control and that the person is struggling to kind of cope with this situation. Same sort of format. So listing out what are those precursors that contribute to out of control situations and what do we do about them? Who's supposed to be doing it? And how long, how often, how much of it should be done? So another example. So when Donnie clenches his fist and paces around quietly, we know that that means he's upset. So at that point, staff should empathize with him. Hey, Donnie, you seem really upset. And they should walk beside him. Staff shouldn't touch him. They should say, hey, I know in the past that listening to music has helped you through rough times. You want to give it a try? If Donnie doesn't respond, then staff say, all right, man, I'll be right over there. I'm here to talk when you're ready. I'll come back and check on you in 10 minutes. And staff should repeat this every 10 minutes while Donnie is pacing with his fist clenched. So specific things to do in response to a precursor. You know who's responsible, and the person responsible knows how much they're responsible for doing, how often, how long, etc. So those are all the pieces that we're doing to prevent a challenging situation. Now we need to try to figure out when are we going to recognize that this is moving from prevention to responding to a crisis situation? So only now have we moved to actually reacting. So again, the same format. So what sort of things would have to happen that would let us know that we've arrived or are almost at that out of control peak, and what are we going to do about it? Who's going to do it, and how long should they do it? So if Donnie's punching his housemate in the face, then we should probably utilize a two-person CPI hold long enough for Donnie's housemate to get out of the way. And then once Donnie is no longer trying to hit somebody, then we immediately release it. And we should repeat that as often as he's continuing to hit somebody. So specific actions that can be taken, or what not, so that we know what is most likely to be successful and what might make the situation worse. So recognizing that these are the things that indicate that we're into that out of control peak, or that we're going to be there really quickly, and then what we're going to do to maintain safety as fast as possible. And then the last section, is what we're going to do when we starting the de-escalating phase. So we've gotten past that out of control peak, and now the person's starting to come down, but it's still a really stressful, challenging situation that could just as easily go right back to out of control. What are staff going to do, or what are the specific things that we're going to do to support the person positively to continue to de-escalate as quickly as possible? Who's going to do it? So it might be director of staff, it might be somebody else, and how long should they do that? This is where it's really important to recognize how long the person stays upset. If they stay upset for a really long time, it's probably not going to be good enough to spend 10 minutes on supporting them to de-escalate, when in the past they've stayed upset for hours. So this is why it's really important that we use strategies, and that we plan to use strategies that are appropriate to the person and the situations that have happened. And then the last parts of the safety crisis plan template that's included in the directive is how are you going to document that you've implemented this plan? So how are you going to use it? How are you going to document that you have used it? Where will it be documented at? And finally, how are you going to communicate the use of the plan? I can't click with the left hand. How are you going to use the use of the plan to the other members of the team? So how are you going to make sure that everybody's on board, everybody's aware of it, everybody has the newest version, and everybody's implementing the same thing? And this might be parents that are involved, it might be the guardian, could be a support, or should be the support coordinator. An individual should know exactly what's in their plan, and what to expect, and in what order things happen. And it's going to describe how and when you're going to use the plan, and how it will be communicated, how often you're going to be revising it. A good example might be, this document will be reviewed and revised if necessary after every incident that occurs, and will also be reviewed and revised quarterly. Just as an example, but making sure that we have a plan in place on how we're going to continuously update and communicate those updates out to everybody. So the bottom line is, when we're identifying all those things that, if they were present, would prevent crisis, and then making sure those things are actually in place, while also having strategies that we decide ahead of time, so not in the moment, but decide ahead of time, that are both least restrictive and most likely to respond to a challenging situation safely, that's a safety crisis plan. Safety crisis plans do not limit rights. They actually promote rights, because they consider what the individual wants and needs. They also get the input of the individual, and they ensure that at any moment in the process, we're always responding in a way that's least restrictive. Finally, we owe it to the individual to plan ahead of time and have these things in place. We also owe it to the director of staff that are going to be responsible for implementing these strategies on a day-to-day basis to have a plan in place. It just makes sense for everybody involved to think about what we're going to do ahead of time and then carry it out. There was a question about where can you get a copy of the template and the full PowerPoint presentation. I believe that all of that will be sent out with the blast after this training, whenever the training goes up on the website. I also will point you to the division's website under directives. There is a copy of the directive. There's a copy of the tool. So you can go ahead and get access to that right now. But the recording and the PowerPoint will be available as soon as the technology masterminds here are able to edit and make me sound smart and put it up on the website. Are there any other questions? Bye-bye. But it doesn't look like we have any questions. I'll go ahead. Well, there's a question. How is a reactive strategy a restrictive intervention, not a rights restriction? So, I think in practice it doesn't really matter a whole lot, but a way to think about it is a rights restriction is something that you've decided to put in place, so you're not going to have, the person's not going to have access to something, or something's going to be restricted, the rights are going to be limited, but the restrictive intervention is how you're actually going to enforce the rights restriction. So you can think about the rights restriction being the thing you're going to restrict, and the restrictive intervention is about the plan on how you're going to actually restrict it, how you're going to carry it out. And the thing to remember when it comes to safety crisis plans is that if you have a restrictive intervention that you're using in reaction to a challenging situation, then that's when you need a safety crisis plan. So a comment or question in the beginning, you said that the safety crisis template needs to be incorporated into the ISP, which is the service coordinator's responsibility. So a safety crisis plan, if necessary or indicated, should be incorporated into the individual support plan, which is the service coordinator's responsibility. However, it doesn't have to be specifically this template. It's a good template. I like it. You can use it if you want. It also means that it's not the sole responsibility of the service coordinator to create the safety crisis plan. So it should be a team effort. Everybody comes together, and that whatever that document that it gets created by the team should be incorporated in the safety crisis plan. The safety crisis plan could be an addendum. It could be part of the body of the individual service plan. As long as it's included with the ISP, that's fine. So an addendum's fine if it's within the plan year and you don't want to rewrite the plan. I don't think that matters. It's as long as it's in there somewhere.
So we have a question. It seems like a lot of responsibility for updating the documents and sending them out is going to fall on the support coordinator. Is there a time frame that these updates have to be completed by? Before anybody needs them would be my suggestion. So as soon as possible. I don't know that it makes sense to put a time frame on there because it's a crisis plan, so it needs to be done before the next crisis is a reasonable response. So as soon as possible.
And recognize that, again, it doesn't necessarily have to fall on the service coordinator to do this updating, but that's one of those things that planning teams need to talk about ahead of time. I talked about one of the common questions is who writes it. Decide ahead of time. Just, when you're figuring out who's going to write it, you should also figure out how are the updates going to be pushed out? Who's going to be responsible for that? Where does the original document get kept? those are things that you should decide as a team ahead of time. And so it doesn't necessarily have to be the service coordinator. It could be the professional manager. So it's just going to depend on what the needs of the teams are and what they come up with ahead of time.
But ultimately, the support plan is the responsibility of the service coordinator, and the safety crisis plan is part of the support plan. So, you know, the support coordinator has to make sure it happens.
Good question. Any other questions out there? So we had a question. Some of the crisis happens daily. So if it has to be reviewed every time and revised, it could be constantly changing. There are some clients that have situations that occur daily and weekly. So my suggestion to you would be that if you are having crises happen on a daily basis and you find yourself having to review and revise the safety crisis plan on a daily basis, that should be an indicator of two things. One, the strategies that you're using aren't effective, and two, you need more help. That would be an opportunity to get extra help, because that would be an indicator to the team that they don't have the necessary resources or expertise available to address the situation. And that's not a good or a bad thing. It's just recognizing that you need extra help.
So it may, for a period of time, need to be revised every time you use it. Or you may find, we use the safety crisis plan, it was successful in de-escalating the situation, keep going. So it's just, the review is just, did it work the way we wanted it to, or do we need to do something different?
Right, and again, just to say it one more time, a good, quick and easy definition of did it work is if somebody got hurt, somebody got arrested, cops got called, went to the hospital, had to use a restraint, that would be an indicator that it did not work. If you de-escalated successfully and no emergency procedures were needed, nobody had to call the cops, nobody got hurt, that would be an indicator that it worked. So those are things that you should be considering when you're doing your review after using your safety crisis plan.
There was another question that said, it stated that it's not the CM, I guess that's case manager, the people we call support coordinators' responsibility. But at this time, we're having issues with providers and BSP providers, so those would be behavioral support providers, not really assisting us. Therefore, it would fall on the case manager to do everything. If you're having a situation where you're finding a lot of uncooperativeness, difficulty getting providers, whether that be residential or behavioral providers, to work together as a team, I think you've got an issue where you want to talk to your TCM TAC and maybe look at the provider relations rep or get the area behavior analyst involved. That's a problem that needs a regional safety crisis plan that needs more people involved in solving your non-cooperative issues. So think about, again, not doing everything by yourself, just like we say that for support staff. They don't have to figure out what to do in a crisis by themselves. We're helping them with the safety crisis plan. If you're having an issue with cooperativeness and getting assistance from providers, you don't have to do that by yourself. Get some help.
Another question, person was talking about a situation they were recently in where the service coordinator, it sounds like the service coordinator wanted a safety crisis plan, but the rest of the team said that it was addressed in the behavior support plan already. The question seems to be who gets to decide whether or not there's a safety crisis plan. So consensus is important on situations that a safety crisis plan isn't required, but once the safety crisis plan is required, then which again is if you're using reactive strategies that are also restrictions, then that's not a choice. The team doesn't get to decide that they would rather not make a safety crisis plan. In that situation, they have to have a safety crisis plan. Now, whether or not the behavior support plan that's in place, it has a safety crisis plan, and whether or not that's enough, I can't say because I haven't seen it. But I think this is another one of those situations that Dr. Rogers was just talking about, that if you get in these disagreements and you feel like you're not able to successfully resolve them kind of amongst the team, then you're getting other people involved, whether that be TCM TAC, whether that be the regional office, whether that be an area behavior analyst like myself, where we can offer some extra kind of guidance or maybe a second check just to kind of see if there's anything that we can do to help. But just, I guess, the takeaway would be, if you're using reactive strategies that are restrictive, you need a safety crisis plan. And that you don't need to have a consensus for that. You have to have one. Anything else on that?
So, if there is also a behavior support plan, the behavior support plan should incorporate the safety crisis plan.
Yes.
So everything should be working together. I don't know how you would have a behavior support plan that did not have a what to do about the behavior when it happens section, which is the safety crisis plan. So again, we can't address that specific without seeing that specific issue, but in general, that's the answer. So we have a question, is there not a fear that if someone who is not a registered behavior therapist, so that would be a licensed behavior analyst, writes these strategies and they're unsuccessful and they result in an ER visit or something like that, then the team will be liable? So let me try to take all the double negatives out so I can understand that question. Is there a fear that if a non-licensed person writes the plan and something bad happens, that the team will be liable? So if the team agrees on it and has done all due diligence and assessment, and if the plan is implemented as described, and still it results in a crisis, then you've done everything that you can do, and you've done your due diligence, and your liability is as limited as possible. And that's as best as I can say it.
Mm-hmm.
If there was no plan and something bad happened, you're far more liable. And this is not a plan that requires a licensed person to write it. If you're in a situation with behavior that is so significant that it does warrant a licensed person, then as soon as we can, we should get a licensed person involved in care. But waiting until you have that licensed person puts you at far more liability than having the plan ahead of time. So until that time that you have the licensed person, you should still have a plan that helps everybody do as best as they can. That's how you limit liability. Mm-hmm. So there's a question of, is the current template that is available going to be approved? I'm not sure what approved means. That current template that's in the directive is an example of one that we highly recommend. It's not going to be approved or disapproved because there's no such process.
It's kind of the same thing with an ISP. There's not
one official approved necessary template, but it is the one we're recommending, so in that sense it is approved. Does it cover everything that's absolutely needed? It's a general template that includes the parts of a crisis safety plan as far as we've researched them so far. So I would say yes. Is there going to be an addition or revision following this training? I don't anticipate any revision of the safety crisis plan at this point unless someone has an idea of what's missing and presents it to us. Just like everything else, we'll always be updating it if we find more information. So, for example, the state-approved ISP template that's available on the DMH website, this is recommended for all case managers to use. Is this the same for this template? If you have to have a yes or no to this, the answer is yes, I recommend it. I don't really have that power, but if you want to believe it, you can. We are providing this template as an aid for you. So, to help you understand what a safety crisis plan should look like or could look like. Okay. I don't see any other questions. So are there any other questions? Okay. You want me to say it? Okay.
Close it out.
Yeah, I would, wrap them up and send them on the way, remind them to do the survey.
All right, so it looks like we've covered all the questions that have been presented. Thank you all for joining us. Remember, quick reminder, there is that 3-question survey that's going to be coming around at the end of this. Please take advantage of it. And I appreciate everybody's attendance. Looks like most of you made it through the whole thing. I really appreciate it. If you have any questions after we get done with this, remember you can always reach out to myself or Dr. Rogers. Go to the next slide. You can reach out to one of the area behavior analysts. I'm in the middle. I'm Lucas. I'm in the central region. Any of you on the call that might be from other parts of the state, take note of your area behavior analyst. You got Rita in the west and Atlanta in the east. Feel free to reach out to one of us, and we can help kind of answer your question. And also, feel free to reach out to us if you have any other issues you need help with. We're kind of nice people. And that's all I got. Thank you all.